Welcome to The Art of Medicine, the program that explores the arts, business, and clinical aspects of the practice of medicine. I'm Dr. Andrew Wilner, and today my guest is Dr. Stephen Landy. Welcome, Dr. Landy.
Thank you, Dr. Wilner. I appreciate the invite.
Well, I had the pleasure of going to a lecture that you did on migraine and Botox, and I was really impressed at your experience, 39 years, right, as a practicing neurologist now in Tupelo, Mississippi, and specializing in headache. And as a neurologist, you learn there's only two kinds of headaches, right? There's headaches that are due to life-threatening, terrible things, a brain tumor, or a stroke or bleeding in the brain. And then there's primary headaches that just show up, right? And of course, those can be subdivided into many, many types. But so you specialize now in the treatment of these primary headaches. Is that correct?
Yes. So I've been involved in headache from a practice standpoint primarily, but education, research, publications. Got involved with a lot of the migraine-specific medications that came out, were FDA approved in the early 90s, and primarily migraine oriented.
All right, let me stop you there. Tell us
Yeah.
what's migraine? Why is that special?
Oh, it's special because, as you mentioned so well, it's a primary headache, and it is, as far as what healthcare providers see, the most common form of primary headache. Frequently taught in med school and even in neurology residency, Andrew, as a unilateral throbbing headache with nausea, light and sound sensitivity, frequently preceded by an aura, which is usually visual, bright lights, visual field cut, which usually lasts somewhere between 5 and 60 minutes. So that's like a textbook presentation of migraine. What happens in clinical practice is we see this spectrum of migraine. So it can be bilateral, non-throbbing. I think the key component of migraine that differentiates it from other primary headaches or even secondary headaches, and the other primary headaches are primarily tension type headache, which is really not disabling, and then cluster headache, which is quite different, is that migraine is usually episodic, usually lasts somewhere between 4 and 72 hours. And then during the intervals of headache freedom, the patient is fine. And the headache is frequently associated with nausea, light and sound sensitivity, and is disabling. The patients like to get in a dark, quiet room. So it's a rather easy diagnosis to make if you consider the spectrum, that not all migraine is unilateral and throbbing, but there are various degrees of migraine from a pain and sensitivity standpoint, various degrees of migraine from a disability standpoint, but it's usually disabling, and it is so common. I mean, for the average neurologist, the most common complaint we see.
Well, I'm going to make a comment first for those non-physicians listening and watching. You're emphasizing all the clinical aspects and that you would get from the patient and historical, because there's no test for migraine. There's no blood test. There's no scan. There's no objective way to say, yes, you have migraine. And so it's very important for the patient to talk with the doctor, right? And for the doctor to listen and ask the right questions so he can determine, yes, that's migraine, because that's going to channel into the treatment, right? Your treatment is going to be migraine specific, but you got to know that it's migraine to start out with.
Oh, you said that so perfectly well.
All right. So now you tell me, how common is it?
So it's 12% of the population.
So what, more than 1 in 10?
Oh, yes. 18% of women, probably at least 6% of men, 4% of children. Very common. Now that's in the population. I would say probably about 50% of those folks don't see a healthcare provider. They're lucky. I can tell you that 40% of the migraine population has 4 or more migraines a day, is
Wow.
very disabled, and should be seeing a healthcare provider. And you're right, uh, there's no marker for diagnosis, there's no predictor of treatment response. So, the practice of medicine, the art of medicine, the science of medicine, it is very individualized when it comes to the patient, because migraine is different from patient to patient, and even in the same patient from attack to attack. So you have to develop a relationship with the patient to really
Right.
understand kind of what's going on in their life, or what's going on maybe with their genes, because there's a strong family history usually, what's going on in their environment, what other medical diseases they have, and consider all that when you're, not only making the diagnosis, but probably more importantly, coming up with the treatment plan.
Right. I think, it's really important to give it a name because migraine, and I want you to tell me about triggers, because if you can identify triggers, then you can avoid triggers. But first, you got to know that you've got migraine so you can be on the alert. What are some of the common triggers that say you could avoid, and maybe have fewer headaches without taking any medication?
Oh yeah, it's a really good point. So most migraine patients have triggers. Um, and I think it's important to identify those, for the patients to identify those, and they usually can. And if they're having a difficult time or a challenging time identifying those triggers, I recommend they try to keep a headache diary and take notes and kind of write down the days they have a migraine, and maybe what they did the day before or the night before the migraine came on. And frequently it's stress, a missed meal or delayed meal, a change in their sleep habits or exercise habits, some kind of alteration in their normal pattern seems to be a frequent trigger. For example, there is what we call weekend migraine, where the person works all week or goes to school all week, and then they're really looking forward to the weekend, and boom, they wake up on Saturday morning with a migraine. That's because they've changed their routine, their schedule. So I kind of look at that and know that migraine triggers, just like the headaches, vary from patient to patient. And they're not that consistent in some patients. And I think in the ones that they're inconsistent, you need to consider trigger stacking, where they missed a meal, they've not slept well, they're stressed, and all that stacks up. And basically overcomes the threshold to the development of the migraine.
I'm going to tell you, I'm one of the 12% that has migraine ever since I was in college. And of course, at that time, I didn't really know what it was. When I became a neurologist, I got a little more insightful and started hunting for triggers. So I'm going to tell you a trigger story. I used to work in Charlotte, and I was on call fairly frequently. But if I had a break, there was a restaurant that had a little outdoor cafe, and the weather's pretty good in Charlotte. And they would have a wine of the day. So I would always have, the house wine with the sandwich. It didn't impair me too much. But I noticed that after I ate at the restaurant, I often had a migraine. And I didn't put it together for a long, long time, because there's a lot of other things going on. And one day I said, every time I eat there, then I thought, I don't drink much. And I thought maybe it's that free glass of wine. So I went back to the restaurant and I asked them, I said, what do you serve on your free wine, that comes with the meal? They said, oh, it's always a Merlot. And so I took an experiment, when I was off, I said, oh, I drink a little Merlot. Sure enough, 8 times out of 10, when I drink a Merlot, I get a migraine.
Oh,
So, as you say, it's not, I think triggers can be difficult to identify because they're not always, it's not like every time I miss a meal, I get a headache, and it's not every time, but I can rarely get away with drinking Merlot. So they're off the list. We don't buy those.
well, you're smart, Andrew. We all know that. And it's interesting that you mentioned the Merlot because it is more frequent with the red wine than like the Chardonnays. So yeah, it's very
All
interesting.
right. Now, suppose I'm alert. I've talked to you. I've got my triggers. I'm controlling everything that I can do, but I'm still having migraines. What's the next step?
And that's usually the case. I mean, triggers are partly responsible, but not totally responsible for the migraine frequency. So, I kind of look into disability, how's it affecting your life? And almost every time, if they're seeing me or seeing a neurologist like you, there's significant impact. So there's not only pain, there's disability, and then you go for the frequency of this pain and disability. And interestingly enough, from a diagnostic standpoint, if it's 15 or more days a month, that's chronic migraine. And that's only 10% of the migraine population. And as I mentioned, it's pretty frequent that the migraine patients that we're seeing, it's 4 or more days a month. So you're immediately starting to think, okay, this patient needs to think about triggers. They need to think about, getting in a routine, relaxing more, sleeping better, not missing or delaying meals. But I think what becomes more important is they need a symptomatic or abortive medication.
So something to take when they get the headache.
Absolutely. And been just huge breakthroughs in my professional career. As I mentioned in the early 90s, I kind of got involved in research. The triptan class, 7 of those. The first one out was Imitrex. And then in the last year and a half, a new class has come out called GPANTs. These are migraine specific drugs that address the pain pathophysiology of migraine. Very different than just kind of putting a band-aid on the problem, which is the over-the-counter medications like BC powders and Excedrin. So, we go ahead and treat symptomatically, preferably in patients that aren't doing so well with over-the-counter medicine. We give them migraine-specific medicine. And then if it's 4 or more days a month, we're thinking about prevention as well. Not only non-pharmacologic prevention, but medication prevention. And we have really good medicine for that too. It was repurposed medicine till the last few years. Drugs that came out with a totally different indication than migraine, found to be helpful for migraine. But there were side effects. Efficacy wasn't that good because they weren't migraine specific either. So in the last few years, we now have migraine specific medication. And those have made things a lot better, a lot easier for the patient, better tolerated, more efficacious. And then, I appreciate you so much, as faculty coming to that discussion we had a few months back, with your residents. I was very impressed. But in 2010, Botox was FDA approved for the chronic migraine group of patients. And that was a big breakthrough too.
Now, is that the same Botox that I should probably use for my wrinkles? That's the same stuff?
I don't know. You look distinguished as those wrinkles, Andrew. But it is the same stuff, yes. It's just administered very different than you would administer it, aesthetically.
Mm-hmm. And it's for migraine.
Oh, FDA approved for chronic migraine.
So more than 15 days a month. Now, do you have any patients in your practice that you give Botox to?
Oh, yes. Yeah, I have many. And, it's been interesting since 2010 because I don't think most physicians before then, unless they were doing migraine research, were really differentiating migraine patients as episodic versus chronic. And, I direct a headache clinic. So, I'm not seeing straightforward migraine all the time. I'm seeing the spectrum of migraine. And within that spectrum, it's not only days um, where the headache frequency is different, the presentation of their migraine is different from attack to attack. But these folks that I see, over 50% actually have chronic migraine. So
Mm.
they're, a good candidate for Botox if they haven't received it in the past, and they wouldn't be seeing me if they were doing well. So it's been a nice option that's helped a whole lot of folks.
So you may not be able to get rid of every single headache, but if they're having 15 days a month, maybe you can get them to 5 days a month, and maybe the headaches don't last as long or aren't as severe. Is that right?
That's exactly the idea. It's realistic expectations. We're the majority of migraine patients that are responders to whatever prevention, including Botox. You're not going to eliminate all their migraines, but you'll reduce the frequency, intensity, and duration, and actually may improve their response to their symptomatic or abortive treatments.
Now,
So
like you said, it's
well,
genetic, right? So we
okay.
don't not yet anyway. We can't remove that gene. So you're kind of stuck with the gene, at least for now. But symptomatically, so two questions. What percent of your patients do you think improve their migraines after you've diagnosed them and explained it by lifestyle modification? Getting enough sleep, diet, triggers. How many patients actually make some headway with that?
You brought up some really good points. Just making the diagnosis is important. And then, having this discussion, you know, about migraine, differentiating episodic from chronic, what you can do to help yourself. Um, I've done some research related to this, Andrew. It looks like about 50%.
Mm.
Now, could you have helped them more, with the medication too? Probably. But just a good education without anything else, making the diagnosis, educating the patient appropriately, avoiding triggers, lifestyle changes. I think it helps at least 50%.
I know once I figured out what was going on and why my head hurt so much, and
Hmm.
I started identifying triggers, sleep deprivation for me was huge. If I was sleep deprived, because usually I used to lecture all over the country, and of course I'd work all day, get on the plane and fly there so I could give the talk. And I realized that when I traveled and was tired, the chances of me getting a migraine went way, way up. And so I started just going home after work and traveling early the next day. And jet fuel causes migraines for me. When I go to the airport, if I smell that, jet fuel in the air, bang, migraine. If I'm well rested, maybe I'll get through it and I won't get it. So I think, just knowing what's wrong with you. So I think people with headaches have a lot of potential benefit from seeing a specialist who understands headaches.
Just like you do. I totally agree with that, 100%. To see somebody, if you're going to get evaluated, that, has an interest, a special interest in headache and specifically migraine if possible.
Now you're in Tupelo, Mississippi. Are you still accepting new patients?
Yes, Andrew. Yeah,
All right. So you're in the book, Dr. Stephen Landy, Tupelo, Mississippi, headache. They can find you no problem.
easily.
Wonderful.
Life has become easy from a communication standpoint if it's done correctly.
Right. Well, Dr. Landy, I want to thank you very much for participating in this interesting discussion. I've enjoyed talking with you about migraine and learned a little bit. It's been great.
Likewise, it's been a pleasure for me as well. Thank you so much, Andrew.
Thanks for joining me on The Art of Medicine.
This program is hosted, edited, and produced by Andrew Wilner, MD, FACP, FAAN. Guests receive no financial compensation for their appearance on The Art of Medicine. Andrew Wilner, MD, is Associate Professor of Neurology at the University of Tennessee Health Science Center, Memphis, Tennessee. Views, thoughts, and opinions expressed on this program belong solely to Dr. Wilner and his guests and not necessarily to their employers, organizations, or other group or individual. While this program intends to be informative, it is meant for entertainment purposes only. The Art of Medicine does not offer professional financial, legal, or medical advice. Dr. Wilner and his guests assume no responsibility or liability for any damages, financial or otherwise, that arise in connection with consuming this program's content. Thanks for watching. For more episodes of The Art of Medicine, please subscribe. www.andrewwilner.com